Welcome today. My name is Bethany Corder and I work at the Mammon Family Public Library. I'm so happy that Kathy is here with us from the Hope Hospice here in Bulverde. If you have any questions after the presentation, we welcome you to actually email Kathy. Her email address is kmiller@hopehospice.net. Also, you can just email me. Most of you probably know me here at the library, and I can get a message to Kathy for you, or you can Google Hope Hospice of Bulverde and find some contact information there as well. I'm going to turn it over to Kathy now.
Thanks, Bethany. Like Bethany said, my name is Kathy Miller, and I am a social worker here in Bulverde at the Hope Hospice office. I've been with Hope for almost 3 years now. Originally, I was a social worker at a long-term care facility, and so I was familiar with Hope. And then my brother moved in with me and needed hospice, and so I utilized Hope, and then just kind of felt called to go back to school, get a master's, and try to work for Hope, which I do now. So there's a lot of misconceptions about what hospice is. So I kind of want to try to dispel some of those and give you some information, more facts than myths. And hopefully it'll clear up maybe some confusion or some questions that you have. And like Bethany said, you can always email me afterwards if you have any specific questions or anything, and I'd be glad to help you. So what is hospice? So hospice it's patient and family centered, and it focuses on the quality of life. So as a team, we're not going to work just with the patient, and we're not going to work just with the family. It's a full team effort, and we just want to have the best quality of life possible for our patients. Hospice has been in the United States for about 46 years, and Hope Hospice has been in New Braunfels for almost all of those. It's been there for 35 years. And it is actually a nonprofit. It's the only nonprofit between San Antonio and Austin. And it is probably one of the few hometown hospices around. Some national statistics. So about 80% of us would want to die at home. But the reality is about 60% are going to end up dying in the hospital, and 20% of us are going to end up dying in a nursing facility. So we're not really, at the end of our life, we're not really able to do it how we want to. And, you know, a lot of times people think, oh, a lot of people just keel over of a heart attack or whatever. But the truth is that 90% of us are going to die after a long period with a chronic illness, and we're going to have a gradual deterioration until we do pass away. What hospice is not, this kind of gets into some of the myths. Hospice is not a way to hasten death. That's not our goal. It's not a form of assisted suicide. Obviously it's illegal, but that's also not what our philosophy is. It's not about giving up. That's not what we want people to do. It's not only for the last few days of life, and it's not expensive. For most people, a lot of people that we do have on service are over 65. If you have Medicare, it pays for hospice 100%. Medicaid will pay for hospice. A lot of insurance as well. And then for Hope, again, because we're a nonprofit, we actually have community assistance. So we don't turn people down if they can't pay. So today I kind of want to look at the 5 Ws of hospice care. We're going to look at who's eligible, what does hospice care provide, when should hospice care be provided, where is it provided, and why is it important to have? So the first one is who's eligible for hospice. So anybody that's been diagnosed with a life-limiting condition, excuse me, with a prognosis of 6 months or less if the disease runs its course. So a doctor has to say basically that he or she would be surprised if someone is around after 6 months if this disease follows its normal course. For someone who has frequent hospitalizations or ER visits in the past 6 months, someone with a progressive weight loss, sometimes that's due to end of life, and sometimes it's due to a specific disease, increasing weakness and fatigue resulting in frequent falls. Here's a big one, a change in cognitive and functional abilities. So if grandma was doing really good 6 months ago, even 4 months ago, and now she can't find things, she's not able to remember where things are, you know, she's just having a decline that way, that could be a sign. Someone with compromised activities of daily living. So dressing yourself, being able to make your own meals, feeding yourself, taking your own shower, deteriorating mental abilities, that kind of goes with the change in cognitive. Recurrent infections like urinary tract infections, upper respiratory infections, stuff like that. Skin breakdown, a lot of times skin breakdown is because someone is not getting out of bed and moving as much as they used to. And so that's kind of a sign that maybe they're having a decline and they might be eligible. And then a specific decline in a condition. I'm not going to get real medical, mainly because I'm a social worker and I don't do that. But a lot of chronic diseases have specific symptoms that happen towards the end of life. And so again, your doctor is going to be the one, or their doctor is going to be the one to kind of have that conversation with and see if someone's eligible. And what services does hospice provide? So everybody that's on or any hospice care, you have what's called an interdisciplinary team. So that team is comprised of a nurse, a registered nurse, and there's always a nurse available 24/7. It might not be the assigned nurse, but there's always one available. There's always a physician assigned. So nurses have a doctor they can call at any time, a social worker, like what I do, and there's always a social worker available 24/7. And there's also a chaplain or spiritual support. Not everybody believes in a certain religion. Some people are more spiritual, and that's fine. Our chaplains are pretty much non-denominational, but they can help you find a specific, like a priest or something if you need it. And we have home health aides that help with bathing and showering. We provide prescriptions for pain and symptom control and for those associated with the admitted diagnosis. So if someone's admitted with a heart problem and they take specific medicines for that heart problem, so then hospice would start taking care of that. If someone's admitted for Alzheimer's, then the heart medications are not part of it. Medical equipment and supplies. Some people can benefit from a hospital bed, oxygen, shower chairs, incontinence supplies, all that kind of stuff is included. We also do things such as respite stays. So if you're excuse me, if you're a primary care provider, let's say for your mom, and you just are really tired or you have to go out of town for a couple of days, your hospice team can help you make arrangements for your loved one to go into a facility for 5 days. And it's part of the benefit. We have volunteers that can come out. We try to do a little bit of a questionnaire, kind of find out what somebody likes, hobbies, stuff like that, and try to match up our volunteers that come out and just sit and keep them company for an hour or so. We do sometimes have therapists that come out, like physical therapy, to help someone. Maybe they just need to figure out how to transfer better. You have to figure out how to transfer them or something. And then kind of one of the more important things that people don't think about is we have follow-up bereavement care. So a hospice will follow the family after someone passes away for 13 months. So like for us, for Hope, we have a full bereavement staff. We have a bereavement center. So we have counselors, we have camps. And so every hospice is different. But we have camps for children. We have a camp for families. We do a memorial quilt every year. But there will be follow-up for bereavement after the loss of someone. So when should hospice care be started? This is kind of something that I think is really a confusing thing. My take on it is sooner rather than later. I always feel like that as soon as someone meets the qualifying criteria, he or she becomes eligible, but not everybody seeks hospice care initially. And maybe that goes back to the myth that going on hospice is giving up, or it's just gonna make someone die quicker. So some of the benefits of starting sooner rather than later include that the patient and the family's focus can start becoming quality of life and not quantity. It's assistance for people who are having increasing difficulty taking care of themselves. So you get the whole team to come in and help them. It allows more time to manage pain and provide effective symptom control rather than just trying to do it at the very end of life. And maybe most importantly, it allows time to build relationship and trust between the staff and the family. You know, somebody being on hospice service is a very intimate relationship. And so your hospice team is going to be involved in that. And so if you have time to build relationships and trust with the staff, I think it's easier to get the full benefit when the time comes. Where is hospice care provided? Wherever someone lives is pretty much the answer, wherever someone considers their home. So whether it's their actual home, the home of a family member, assisted living facility or private care home, a nursing home, we have had people who live in a shed. And so we provide services to that person there. Maybe they're homeless and they live in a tent. So we provide services there. It's wherever somebody considers home. And we also can provide services briefly inpatient at a hospital for acute symptom management. So if the medicines we provide at home are not good enough then to control the pain, then the person can go briefly into a hospital, excuse me, and get the symptoms under control and then go back home. So why is it important? So the main reason is it helps the patient remain in control of his or her life. They get to make the decisions on their treatment. If they want to stay at home, then that's our goal, to keep them at home. They guide us. They drive the ship, and we always look to the patient. We always look to the family to see what is important for them. You know, what do you see this like? And then we try to make that a reality. It improves the patient's quality of life by focusing on comfort, pain control, symptom management. And so when we control that stuff for the patient, we also help the family. Nobody wants to see a loved one in pain. So again, it's not just the patient, it includes the family. Well, that's the next one. The hospice team supports the family as well as the patient in whatever way they see is what they need. And then of course the follow-up bereavement services to help everybody through that first year, the first birthday, first anniversary, all those critical times. So we do that too. Look at that. So here's some helpful resources. These are just some of the websites that I think have some really good information, not just about hospice, but about just end of life, different options, stuff like that. And then there's also our web address, hopehospice.net. And again, like Bethany said, you can email me. My email address is the letter K. So it's kmiller@hopehospice.net. Thank you.
Thank you so much.